to Mohammed.
Um, am I speaking in this? Yeah. Assalamu alaikum. So my name is Mohammed, emergency and critical care. And I'm going to talk about a very sensitive topic. Now, it seems to be that most of the attendees are online. So I'm going to talk to my computer probably. But for anyone who's here, we will tackle a very important topic, which usually does not have a straight answer for their questions. So consider this MCQ. So an 81-year-old woman with recurrent colon cancer, and she had liver metastases. She was just discharged from the hospital after chemotherapy. She presented to the emergency department, and you were called to see this patient. This patient was not conscious enough. She was in respiratory distress. She had a weak pulse, so she was pretty sick. There is nothing documented in her electronic medical record with regards to her code status. But her son obviously wants everything done, everything, meaning including CPR. So you give her a fluid bolus, you started her on BiPAP, non-invasive ventilation via face mask, and she appears quite comfortable once you do that. So what would be your next action? If this patient would arrest, would you do full resuscitation? Because you cannot go against the son's request. Would you do full resuscitation because you should not initiate a DNR in the ED? You're now seeing this patient. Would you do a soft code? I don't know if you guys heard of the soft code, but like massage of the chest wall, but not the chest, but not the heart. And because you cannot afford any legal action, or you're just going to sign a DNR anyway. Go ahead, call her oncologist, sign a DNR, and because resuscitating her is frankly futile. What do you think, like those who are here? Right, okay. Okay, let's say you're practicing here. Right. Oh, really? Okay. Okay, so based on local laws, obviously. So why DNR? We will talk about the answer to this MCQ probably at the end. So why DNR? According to the American College, DNR is for people who have, where you think they have futile care because they have a terminal illness. A terminal illness, meaning an illness which will probably end in death soon. Because you don't want to use the resources on someone who's dying anyway. And you always think of the emotional trauma to the patient by doing this, and to the family more importantly, because those who are alive, and then you give them a false hope. But then would you initiate, even if you think this is futile care, would you initiate this in the emergency department? That probably doesn't seem like an ideal situation. You prefer that someone has already addressed this before the patient has presented to your ED. And that's the problem. When these guys looked at 37 patients who presented to their ED, all of them fit criteria for a DNR order. Only 14% had their prior discussion in the ward or in their previous admission, which means that 86% of patients who should be DNR did not have actually discussion prior to their emergency visit. And that's one big problem. And when they discussed with all these 37 patients, actually none of them had significant resistance from their family to a DNR order. So it wasn't that difficult once you discuss the right way. Now, if you look at some local policies, I looked through our own policy in the MOH of Saudi Arabia. So it says if it's a new patient and that new patient is not linked to an MRP, not linked to a specialist. For example, that patient is coming from another hospital, or this is his first presentation to your hospital. Then the ED physician or the on-call medical physician cannot initiate the DNR. The DNR has to be initiated when an MRP is linked. MRP meaning most responsible physician, that's the primary physician. So if this patient has just been having chemotherapy in your hospital, she's discharged 2 weeks ago, it means she's probably has an oncologist linked to her. especially if this patient is high risk of cardiac arrest in the ED. Like this patient, for example, at any time she could arrest. I mean, she looks comfortable now, but she could go into cardiac arrest anytime soon. And you want to discuss this now, because if you don't discuss it with the patient right now, you probably will be discussing this with the family like the next morning when the patient is already on a ventilator post-CPR with a GCS of 3. And discussion with the family, trust me, it's not a good thing. The family are not created equally. So some members of the family have conflicting emotions between themselves. Actually, they're fighting among themselves, brothers and sisters. Some of them are highly emotional, and they would be like, "No, you're not going to kill our mother." Some of them overestimate prognosis, and they think, "Yeah, well, I mean, she does have cancer, metastatic everywhere, but we don't think she's dying anytime soon." And some of them overestimate patient preferences, and they think, like, my mom is a fighter, she's probably want to live for a few more years, even with her cancer. So that's why discussion with a family could be difficult. But then, if you remember, you have this patient in the ED, and then you want to admit. Where would you admit? To the ward or to the critical care session? So in a critical care unit and ICU, we have priorities of admission. And these priorities are worldwide. They're approved by JCI and by our local Sibahi in Saudi as well. I'm not going to talk about all the priorities, but consider priority 4, which is, by definition, patients who will not benefit from critical care. So these patients, at first instance, they seem to be needing an ICU admission, but they would actually not benefit, either because they're too well, and we're not concerned about those, or because they're too sick to benefit from critical care. For example, with irreversible multi-organ dysfunction, terminal malignancy, like Our Lady here in the MCQ, or brain dead, who's not an organ donor, obviously. So by definition, too sick to benefit, we define it as futile care. Now, futile care is a very subjective word. So when you say futile, many patients you would consider treatable, someone else would consider futile. So it is highly vague, highly variable between people. It's subjective. Would you use Apache? Do you guys know what's Apache? In the medical floor, probably you don't use it, but in the critical care session, we use it. Apache scoring is used to predict mortality of a patient. So consider, for example, a patient where you did Apache and you predicted the mortality of 90%. So you know this patient is 90% will die, but there is a 10% chance of survival. So what would you do? By definition, this patient is poor outcome, right? Most likely poor outcome. But then, so would you just run away because it's 90% mortality, or stay and play? And that's what ICU and critical care is all about. So maybe using Apache and scoring systems is not enough to define futile care. Because, I mean, that's what we do. If we're receiving all patients with 100% survival, then that's not an ICU. That's not medical care. One potential problem of DNR, which is supposed to scare you from DNR, is some people use it to DNT. That's not an approved abbreviation, which is do not treat. So look at the spectrum. So most patients fall into the full code category. That's the majority of patients. But then as the disease progresses into being more terminal, more elderly, more multiple medical problems, functional status is too poor, then you start limiting care. And the first thing is you're going to limit CPR. So do not resuscitate, just don't do CPR, but you can do anything else. And then the next step, when the patient is dying anyway, whether you do anything or you don't, and this is the step of comfort care, otherwise known as allow natural death. And then the last step is euthanasia. You guys know what's euthanasia? So it's mostly invented in animals. It's merciful killing. It's, you know, if you've seen old cowboy movies where they shoot the horse because it's hurting, because it's in pain, so that's merciful killing. You're killing the patient because of mercy, but obviously we don't practice euthanasia. Now, The problem is that there's a large discrepancy between what we have put in the form, in the DNR form. Mostly, we mean do not do CPR, do not attempt CPR. But then most of the teams, they actually think it's just comfort care, don't do anything, do not treat. And there has been multiple studies that have shown people withholding antibiotics, people withholding blood product transfusion because the patient was DNR. Now the problem is what families think. And many of the families think actually that you're giving the patient something to hasten their death. And that is one big problem. And if you look at our local DNR order, so it has two options. One of them is called comfort care, which is basically the allow natural death. And then the other option is the limitation of additional interventions, which is basically the basic DNR, do not attempt resuscitation. So, in a DNR order, you need to pick one or the two. Obviously, euthanasia is not one of them. And when you start talking to family, it might be a big challenge. But remember, never only talk about CPR as something beneficial. Always talk about risks of CPR as well. CPR has risks and benefit. You're breaking ribs, you're causing hemorrhage, you're causing lung injury, you're causing vegetative states, you're causing brain death, you're causing chronic ventilated patients on a tracheostomy and a PEG tube. So CPR is not actually a holy grail of saving people. And one very important aspect is that we need to make sure that the family know that we do not practice euthanasia. No one practices euthanasia. I mean, so far, no one practices euthanasia. There's some discussion about physician-assisted death back in Toronto. I think that was just before the COVID, and it's approved in some of the states and in Eastern Europe. That is right. Okay, so most of the time our DNR is one of these two. It's either do not attempt resuscitation or allow natural death. Also, part of the discussion, CPR benefits and risks, part of the discussion is also the CPR outcomes. Now, when people were surveyed, according to one study, they surveyed like a few hundred people about what they think of the CPR outcomes, and they thought that 50% of CPR victims actually survived. But and this is probably influenced by local media. Those of you who are from my age probably remember the ER series. The actual survival of CPR is 15% at best. And this is giving pre-hospital and in-hospital CPR. And this 15% actually did not change in the past 2 decades. There hasn't been any improvement in the CPR outcome. And it is much lower for a cancer patient who already has chronic disease. And post-CPR, remember that we will need aggressive ICU management for the next 2 or 3 weeks if the patient survives. And then it definitely leaves permanent deficits, impaired functional status. So you're not actually producing a functional human being. Now, in this study, James Downer, he actually interviewed 27 patients who wanted DNR and 17 patients who did not want DNR. They refused. And look at their perception. So those who accepted and wanted DNR, they thought CPR was equivalent to suffering and futility, which is what we think as physicians. But those who refused DNR strongly, they thought CPR restores life. So look at the perception difference. Those who accepted DNR, they thought DNR was actually comfort. DNR was natural death. DNR was death with dignity. While those who refused DNR, they thought DNR was below standard care or even euthanasia. Now, the interesting thing is both groups would not want any prolonged period of life support. And I think if you ask many people, this is what they would tell you. Yes, I mean, do CPR, do everything. Okay, what do you think if I just do CPR for like 2 weeks every day? I'm just breaking your... No. Like, if you think I have a reasonable chance of living. So most of them would not want any prolonged period of life support and would not want CPR in the event of a poor quality of life. Now, Let's talk about family consent, because that was mentioned in the MCQ. So in some countries, obviously, family consent is required. According to the Saudi Health Council, and I took it verbatim, so you just need to inform the family about the decision. So you do not ask for their consent, you only inform them. Who decides? The attending physician plus 2 others. So a total of 3. And this is a very interesting sentence. I'm going to read it very slowly. The burden of making the decision DNR should not be placed on the patient or his family. It's a burden. The decision is a great burden. Since it is a medical decision that requires good medical knowledge about the disease and the patient's deterioration, that's why family's permission is not required. They just need to be made aware. So make sure to tell them after you made the decision and sign it. And even when you go religiously, it says the same. بتقرير من 3 من الأطباء المختصين الثقات أن المريض يعتبر مستعصي غير قابل للعلاج وأن الموت محقق. So 3 physicians, and all of them assuring that the patient is dying anyway, whether you do CPR or you don't. ولا يلتفت إلى رأي أولياء المريض في رفع آلات الإنعاش أو وضعها لكون ذلك ليس من اختصاصهم. It's a very important sentence. So if we go back to the MCQ, so would you do full CPR because you cannot go against the son's request? Right. 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 So locally here in Saudi Arabia, at least, like where I come from, would you do CPR? Obviously, I was trained in Canada, by the way, as well, and in Canada we used to ask families' permission as well. But like in Saudi Arabia, that's right. That is right. Always review local policies. Just make sure you go by the local policies and legal to avoid legal actions. Okay, so locally here, what do you think? Or maybe it's not appropriate in the ER. Or maybe you do soft code. Who would do soft code, really? Like, I mean, we've done it. We've all done it. Now, the correct answer, based on local policies, based on all the laws, at least back home in Saudi Arabia, is yes, you can actually sign a DNR, but only together with her primary oncologist. You'd have to speak to her oncologist before you sign this DNR, because obviously resuscitating this terminal cancer patient is considered futile. So I remember one of my mentors, he told me once, Mohammed, when God puts his hands on the patient, you take off yours. Any questions?